Fecal incontinence. Even healthy young adults have difficulty maintaining continence with liquid rectal contents. The patient, if he cannot feel the rectal fullness, overflow may occur before the patient can take appropriate action. Many patients complain of inability to control flatus or slight soilage of undergarments that tends to occur after bowel movements or with straining or coughing. This may be due to local anal problems such as hemorrhoids and skin tags that make it difficult to form a tight anal seal. Especially if stools are somewhat loose, patients should be treated with fiber supplements to provide greater stool bulk. Loose application of a cotton ball near the anal opening may absorb small amounts of fecal leakage. Control of flatus and seepage may be improved by Kegel perineal strengthening exercises. Elderly patients with chronic constipation may develop stool impaction leading to overflow incontinence. Major incontinence. Complete uncontrolled loss of stool reflects a significant problem with sphincteric or neurologic damage. Causes of sphincteric damage include traumatic childbirth, especially forceps delivery, episiotomy, prolapse, prior anal surgery, and physical trauma. Neurologic disruption may be caused by obstetric trauma, that is with pudendal nerve damage, PUDENDAL, pudendal nerve damage, aging, diabetes mellitus, dementia, multiple sclerosis, spinal cord injury, and cauda equina syndrome. Investigations. First one, physical examination, careful inspection, digital examination during relaxation and squeezing gives valuable information about resting tone due to the internal sphincter and external sphincter function and excludes fecal impaction. Anoscopy is required to evaluate hemorrhoids, fissures and fistulas. Proctosigmoidoscopy is useful to exclude rectal carcinoma or proctitis. Anal ultrasonograph is most reliable test for definition of anatomic defects in the external and internal sphincters. Anal manometry and surface electromyograph may also be used to define the severity of weakness, to diagnose nerve injury, and to predict response to biofeedback training. Patients who are incontinent only of loose or liquid stools are treated with bulking agents and antidiarrheal drugs. Example, loperamide 2 mg before meals and prophylactically before social engagements like shopping, trips, etc. Patients with incontinence of solid stool benefit from scheduled toilet use after glycerin suppositories or tap water enemas. Biofeedback training with anal sphincter Kegel exercises is helpful in motivated patients to lower the threshold for awareness of rectal filling or to improve anal sphincter squeeze function or both. Operative management is seldom needed but should be considered in patients with major incontinence due to prior injury to the anal sphincter to have failed medical therapy. So once again, fecal incontinence, minor incontinence, inability to control flatus or slight soilage of undergarments. Treatment: fiber supplements and Kegel perineal strengthening exercises. For major incontinence, complete uncontrolled loss of stool reflects significant problem with sphincteric or neurologic damage. Investigations: physical examination, careful inspection, digital examination, anoscopy, proctosigmoidoscopy, anal ultrasonograph, anal manometry, and surface electromyograph. If it is loose or liquid stools, treatment with loperamide or antidiarrheal drugs, that is antidiarrheal drugs. If the stool is solid, biofeedback training with anal sphincter Kegel exercises. Thank you.